I'm going to record until it dies.
So it's impossible to put a peg tube in the shoulder?
Yes.
Okay, I thought I heard
It's always
people
in
say that.
it's always in the abdomen.
That's what surprised me.
Okay.
I don't want to record me.
So we've got the orders for peg insertion. We'll have to get consent from either the patient or the family. We've got that signed. And we told them what it was for, what the procedure was for. He'll go to surgery or GI to have that inserted. Usually GI can do that.
The stoma?
It's a peg. It's a peg. Yeah, stoma is something. Yeah, stoma is something different. So he's come back. This will be right in the center. Usually, either right below or right above the navel, the umbilicus. So for that day, we won't feed him anything. Okay, he'll be NPO because we don't want him to have aspirations or nausea, nothing like that. So for that day, we'll usually keep him NPO. Tomorrow, the next day, you'll have orders for feeding. If it's just a bolus, what you will do is you'll have a syringe that comes in an irrigation tray.
So do they put that peg tube in like during surgery?
Yes.
Okay. So we are just
Feeding.
feeding him through that.
We won't
him or
have
her.
nothing to do with the peg placement.
Okay.
So,
We only had the consent signed.
Okay.
does it matter the meals of the syringe that you get, or it just doesn't really matter, does it? I mean,
It does
it's a big syringe.
It doesn't matter.
Okay.
You usually get a 20 or 30. Sometimes they'll send you a 50 or a 60 ml. Most of the time it'll be like a 50 ml. Okay. And sometimes they'll ask you to check for residual. Sometimes they won't.
Okay.
But anyway, right now we're just going to feed him. We're going to feed her. And if it's a bolus, they'll tell you only feed 200 mLs 3 times a day. So nutrition will always send you the feedings, dietary. So we're doing a bolus. And you always want to keep the patient up at a 45-degree angle or a height because we want to prevent aspiration. So you can just pour it at gravity, slowly. As long as his head is elevated, he won't be coughing. If he starts coughing, you've got him down too low. Okay? We've got the feeding.
Why would they cough if it's down there? It's not going through their throat.
Because it all it can have reflux.
Okay.
Anyway, we've done the feeding. 3 times a day is ordered. And many times they'll say flush with 100, 200 mLs. They'll specify what they want. Okay. So they wanted 100 mLs of water. So I'm flushing it with 100 mLs of water. Once it's down in the peg line, you squeeze it. If you don't squeeze, if you just pull out your syringe, it's going to burp out. Okay? So be sure and squeeze it. And then it's got a little, we don't use this, but anyway, it's got like a little connector that you'll just apply on the tip. Okay?
So you said they don't use those anymore?
We don't use them at Covenant. They have like a little probe that just goes right in there.
Will we have to wipe that down or anything?
No, as long as this one's not, as long as your connector's not touching anything.
Okay.
What you want to do, once you remove that, you place it on the sleeve of what it came in.
Okay.
Okay? But like I said, we have a little connector that we just connect to the tip. And that's what it'll look like without this little plastic. But if it's got this plastic, that's even better because all you have to do is cover it. And that's going to be like right there. Okay?
So we just snap it closed and you're good to go.
Okay. Okay, now it's not a bolus, it's a continuous. And at Covenant, I'm not sure about yours. At Covenant, the night shift starts the feeding, so they're fed during the night. Usually from 8 to 8 or 7 to 7. but the night people are the ones that will start it. What they will do is, again, on this side, it'll come in something like this. And it'll have the label, what it is. Anyway, this little pump is called a kangaroo. Kangaroo infusion pump. And they'll tell you the rate that they want it. They'll start at a low rate, and then if he can tolerate that, they'll increase it 5/10 mLs. And you just increase it until you reach a target rate. And once you reach a target rate, you leave it at that rate. Again, he's got to tolerate the feedings. So you'll fix the pump. You don't want, you're running your formula through this tubing. It's got a certain tubing. If you put an IV tubing in one of these, it will not work. Your pump will not work. You don't want to fill your whole chamber up. You want just no higher than that little line. I don't know if you can see the little line. You don't want it no further. If
So
it
there's
goes,
a specific tube that is specifically for the
they'll
kangaroo pump?
usually send you the tubing with your feeding. Okay? And you have to, once you've got your, and you can run your feeding a little bit into a trash can just to make sure that it's out. And then you set the rate at whatever they've ordered. The tip is going to go right in this little blue tip. Okay? In the peg side.
And that's a continuous.
And they'll just go right into that peg site. Again, keeping the head of the bed elevated. Okay, so we've done the feeding. Any questions on that?
The head of the bed is at 30 degrees and it needs to be up at least.
You want it
45?
no lower than 30. I usually set mine like at 45.
You okay?
Just to be sure that, the only time you're going to lower the head of the bed is when you're going to bathe him, turn him. If you've got to lower the head of the bed, you've got to stop, or not hold.
Pause.
You hold the feeding. Okay? And then once you
thank
finish
you.
your procedure, raise the head of bed up and restart the feeding. But like I said, most of the time the feedings are done at night. Okay? And with the feedings, you'll always be, the pharmacist or the dietitian will always be checking for glucose, protein, and one more. Glucose, protein, and fats, lipids.
Looks like a blood test or?
So every morning they'll have some kind of a lab work.
Okay.
Well, now we've got to clean this. Whenever they come back from surgery, they'll have like a 4x4 or a sponge dressing over it. That day that they come back, we do nothing to it. We just leave it well enough alone. Okay, but now he's ordered for you to clean it, keep it clean. Again, you're going to come to the patient's room, tell them what you're doing. Never do anything without telling the patient what you're doing, because you're startled. We washed our hands, we've got our supplies.
What are you looking for?
A 4x4, but that's okay. So you can they'll tell you what they want you to clean it with. What you do, you'll remove that 4x4 or the drain sponge that you have. You'll remove it, assess the area. I mean, it's supposed to be just a pretty skin color. If it's red and irritated, be sure and report it. What you want, you can either clean it with just soapy water, or they can tell you to clean it with saline. If they tell you to clean it with saline, what you want to do is moisten your 4x4 with the saline, and you're going to clean. You're going to go from one side with the 4x4, one side to down, okay? Then you can either flip your 4x4 or get you a clean 4x4 and do the other side. What you do not want to do is,
Dab or wipe.
because you just spread whatever was
Right.
here, you spread it all the way around. Go from one side to the other. So, let's say I've got a 4x4 with a saline, just one side, all the way down. Turn your 4x4 or get you a clean 4x4 and do the other side. You usually do not have any orders to apply anything on it. Then you get another clean, sterile 4x4, you pat it dry. Throw that one away, get you another 4x4, pat it dry. And then, they're fenestrated 4x4s, or the drainage sponges, or just cut you at an angle, cut the 4x4. You apply it, your 4x4, or any type of dressing, and then you secure it. Before you secure it on your tape, I would date it, time it, initial. Again, if you don't do that, you never did it. It wasn't changed. I don't care how clean it looks. If it's not date, time, initial, you didn't do it. Then you go back to the nurse's station, you document what you found with any of them. You'll document how he tolerated the feedings, how he tolerated the NG tube, if you're hearing bowel sounds, anything you saw, smelled, anything you observe, see, whatever you see, you smell, and anything abnormal, you're going to document that. And then once they get to go home, sometimes they get to pull these out, and they'll have like a normal. Other times, this is what you live with the rest of your life. And any questions?
I'd hate that.
What's the difference between that and stoma, or is that just something we do later?
A stoma usually goes to the urine, the bladder, ileostomy, or it could be a colostomy, a uterostomy. I mean, there's different types of stomas. But this one's specifically for the
Sticking out whenever you have a ball, like a colostomy or stomas are outside the body.
and you can see like this ridge on the stomas. The other one is just like this little tube is usually right next to the skin. Right next to the skin. Do not give any medications unless it's specifically ordered. If it's a pill, the doctor does not tell you to crush it, do not. I mean, there's no way you can give a pill through here or orally. You have to ask the doctor if he will order it liquid, or if you can crush it. Him and the pharmacist will work together to get the medicines down. Otherwise, nothing unless it's specific. If he does ask you to check for residual, all you're going to do is aspirate. And he'll tell you on the order, whole feedings if it's greater than 100 mLs. Okay, so you got 50 residuals. You're not going to hold a feeding. You're going to simply reconnect, start your kangaroo, and start the feedings. If it's greater than 100,
And what is this gonna look like coming out of there?
sometimes it's bile, sometimes it's the formula, the color of the formula. It just, and whatever most of the time it's the color of the formula. Anyway, if it's greater than 100, you're gonna cap that, and he'll tell you hold it till in the morning, hold feedings 4 hours, he'll be specific as to what he wants you to hold. So if it's greater than 100, just cap your peg site.
So if it's
Report it.
100 or less, we need to continue with the feeding?
If that's what the order tells you.
Okay, and that residual is basically what he's absorbing?
What you pull back, he's not absorbing.
Okay, yeah, but
much is sitting in
that's
the stomach?
telling us what is sitting there, not being
It's
absorbed.
not, he's not absorbing it.
And what are we gonna do with that?
Tube directly inserted into the stomach.
Usually the small valve. It could be right in the, in the in the gastric, and they can also do it in the jejustomy. There's two areas that they can put it. Most of the time it's PEG, P-E-G, or it can be P-E-J, but most of the time it's in the gastric.
I'm just wondering how they, absorb their nutrients if that starts mainly in the small intestine.
Right.
That's where you do most of your absorption.
That's what I was asking.
That's where you do most of it. What were you asking about the?
Oh, what do you do with it?
You're gonna discard it, but you're gonna see what you got.
Okay.
50 mLs of formula, bile, then you can waste it in the trash. Most of the time it's in the sink.
Oh, okay.
And then flush it. Clean your sink up.
So you don't put that back. If you pull it out, you keep it out.
So that was my next question.
I don't. I don't put it back. I've seen others put it back. But I'm like, why would you put it back if he's not absorbing
Right.
it anyway?
Right.
You're
Documented online, I'm sorry, because it's,
you do.
the residual, I mean, you're putting it in, but
Yeah.
Yeah,
If you
because
don't
that's
put
what
that
you
you pulled
pulled
it
out.
out, then
You're gonna
Output.
put
so it's just
residual.
gonna cancel it out. Okay.
You're gonna put residual 100 mLs or whatever he wants you to hold it at.
Right, it does have residual.
Yeah.
So whenever you are, like it says 100 mLs, and once you see you have 100 mLs, do you stop or do you continue to the section?
No, you continue to
Until there's nothing in it.
until you have 150 and nothing else. He said it's greater, 150 residual. But most of the time, if it's greater than 50, greater than 100, he just wants you to hold it. And like again, in the order, it will specify what they want. And then he'll say, every 4 hours, every 6 hours, every 8 hours, whatever, he wants you to flush it. He wants you to flush it with, again, 100 mLs of water. Get your water, and pour it in your syringe, and you're flushed it. And you will include that in your intake. Okay?
How often did you say that you would have to do that?
8 hours?
Just
What
depending on doctors.
What the order says. You always go by what the order says.
So none of this is pretty much in concrete, it's just all pretty much what the doctor says.
Whatever he says. 'Cause some say, don't check any residuals. So how do you know he's absorbing it? But they don't want you to check it, you don't check it. But every 4 hours, whenever you do your vital signs, you're gonna assess the tummy. See if you're having bowel sounds, if he's becoming more distended.
you also take before and we'll do all this.
See this, you'll care to look at it.
Looks pretty much like I thought it did.
And most of them will have like
Yeah.